Okay, we'd like to get started with our EMS Trauma Grand Rounds, and we're happy today to discuss chest trauma. Dr. Zach Foy from the Emergency Department is going to speak on EMS and chest trauma. In January, we'll be having a speaker to speak on pediatric trauma. It'll be the second Wednesday of the month, like it usually is, and you can tune in for that, and we'll turn the time over to Dr. Foy.
Okay, I'll be talking to you three primarily. I mean, I guess I can see the folks in eastern Montana fairly well, and if it's okay with you, I'm going to remain sitting down. But like Russ said, I'm Zach Foy. I'm one of the second-year residents in the emergency department, and we do some EMS stuff, like EMS ride-along. I haven't done mine this year yet, but have done some in the past. I've tried to gear this as best as possible to the pre-hospital setting, because that's, I think, what this kind of outreaches thing is all about. Yeah, that's who I am. That's where I'm from. So this is chest trauma in the pre-hospital setting. The objectives of the lecture, we'll talk about major mechanisms of injury in chest trauma. We can review the anatomy and related physiology, which is obviously pretty important in the chest. The 6 quick killers, we get this. This is probably the most important thing to be really cognizant of in chest trauma, because it mostly involves the chest. And then there's also some other things, the slow killers, so to speak, that will be a little bit less important in the pre-hospital setting, but is probably what we see more of. And then we'll review measures to stabilize and transport the patients as we go along through there. So thoracic trauma, just a background on it, is responsible for about 25% of the trauma deaths in the hospital, or really trauma deaths in the country. More of the patients are reaching the hospital alive, so we're doing a better job stabilizing them, and we're probably doing a little bit better job with some of the prevention as well, seat belts, airbags, that kind of thing. And that's probably why they're reaching the hospital alive. But a lot of these patients are still dying after they hit the hospital, and we can go through some of the reasons for that. To go through the anatomy real quick, you've obviously got your rib cage is protecting everything in here. Broken ribs can be a real problem, and even if you don't have broken ribs, you can still have a lot of disrupted anatomy and physiology in the chest. This is kind of a weak slide. I'm not going to go deeply into the anatomy. That's probably for another discussion. The lungs, the tracheobronchial tree is important to consider, including it includes the larynx, and then inferiorly to that, down to the carina, and you can get disruption of the tracheobronchial tree. The heart is probably the biggest and most important part of the chest trauma. The great vessels, we don't see a lot of trauma of this just because they don't live very well after you get transection of the aorta, that kind of stuff. And then the esophagus is more one of those slow killers that I was mentioning. This is actually, so you have 2 major mechanisms to be considering in trauma, just in general, is penetrating and blunt. This is from an accident. I saw this patient, I think it was Thursday. This was the guy who was driving 100 miles an hour on I-15, shut down I-15 for a long time. This is his car, and we saw him down at IMC, not doing well. And he did have some chest pathology as well. And then you get penetrating trauma as well, which this is just such an impressive picture. This is actually the abdomen. I mean, you can see it kind of going in here, and it does actually go up above the diaphragm on one of the other pictures. But it's just such an impressive picture, I had to include it. That's all. This is more likely what we're going to be seeing. Obviously, the knife's still in there, but it's going to be penetrating a lung. You'd worry about the aorta here. You'd worry about the heart. You can see some doctors in the background standing around with their hands in their pockets. So clearly the patient's either dead or doing really well. So just to review trauma deaths real quickly, death immediately can occur in seconds to minutes, and this is 50% of trauma deaths is from spinal cord injuries, brain injuries, and then lesions of the great vessels. Where this is relevant in chest trauma is obviously the lesions to the great vessels. If these are transected, the patient generally bleeds out. And then brain injuries, oftentimes we would say the patient is dead, even though they may have some physiology. They may have a blood pressure, but they're brain dead, so they're technically dead. This is where it matters. This is where we can make a big difference in the pre-hospital setting, is this golden hour. And obviously thoracic trauma is where this is important. You also get liver spleen injuries, pelvic fractures, major long-bone fractures. I think these three right here, the most important thing to be thinking of is hemorrhaging and losing blood and hypotension from hypovolemia. In thoracic trauma, it's not always hemorrhaging that's going to be causing the biggest problem, and we'll go through that. Obviously, hemorrhaging into your chest is part of one of the 5 places to lose blood, but you can get some other physiology that can actually be very easily corrected, especially in the pre-hospital setting, that doesn't involve hemorrhaging, and so that's where this early and kind of golden hour is important. We see these patients who stay in the hospital for a long time. They get sepsis and multi-organ failure. These are the patients with long bone fractures. They can have some thoracic trauma, liver spleen injuries, but this is the patients who don't do well because of their kind of multi-trauma. So real quickly, the assessment in a trauma evaluation, you obviously do your scene size up. You make sure that it is safe for you, of course, and think about how rapidly you can move the patient from a dangerous situation. There's going to be the initial evaluation, and then the rapid trauma assessment is the same thing that we do in the trauma bay, which is the ABCs, the airway, breathing, and circulation. Chest trauma involves all 3 of these things. Generally, and I have breathing underlined here, airway can be a dynamic and changing thing. Breathing is going to be a dynamic and changing thing, in chest trauma especially. And this is where you have to really make sure that you're following the patient and you're going back and looking at what's going on, especially if things change. Start over again. Make sure that the airway is okay, and then spend some time on breathing. It means observing, palpating, and auscultating the patient. The worst thing that you can miss is going to be a tension pneumothorax, and we'll talk about that. And like I said, right here, this is an ongoing assessment. Circulation, you're going to be repeatedly monitoring this as well, and because the heart's in the chest, it obviously becomes an important part of chest trauma. So the 6 quick killers, our trauma surgeons, do you guys get pimping? Do you know the term pimping? So residents get pimped, which means that one of the trauma surgeons will say, Dr. Foy, what are the 6 quick killers? And this happened last year, and I could only name 5, and I thought aortic transection was one of them, and it's not. So the 6 quick killers, punching Mike Tyson in the gut, that will kill you pretty quick. Jumping off a building is one of the 6 quick killers. That's fairly quick. Driving off a cliff, I think this is from Thelma and Louise, and I don't know for sure. It is? Yeah, you guys recognize that? Avalanche, I love this picture because this guy's still standing up, but he's not going to be very soon. And just as a side note, for those in Montana, this is an excellent avalanche book. It's by a guy in Utah. So, telling your mother-in-law how you really feel, it's just such a good picture. I had to put it in there. And texting while driving. This is actually a picture. I couldn't include the other ones from this series, but it's a picture of a guy driving. So the real 6 quick killers, the ones that I was only able to name 5 of when I got pimped last year. First thing is airway obstruction. This is not that impressive right here, but you can see a little bit of a hematoma forming, and airway obstruction will kill you very quickly. So if you don't have a secure airway, but you think you might lose it, it needs to be secure. This is not a discussion on airway, but it is a discussion on the 6 quick killers in thoracic trauma. And airway obstruction can especially happen in thoracic trauma and should be one of your first thoughts, obviously going through the ABCs. There's 4 of them that deal with breathing in the lungs. So Tension pneumothorax is, like I said earlier, probably one of the most important things in the pre-hospital setting because it's something that can be fairly quickly and easily fixed, but it can kill a patient very quickly as well. This chest x-ray is one that should never have happened. This is a clinical diagnosis, and we'll talk about this in a little bit, but this chest x-ray is so much tension right here, and you can see the heart, the mediastinum, everything being pushed to the right side. You can see some rib fractures here that's probably causing the tension. Open pneumothorax is another one. This is fairly impressive, but I don't think the physiology is actually as severe as a tension pneumothorax. Flail chest is certainly a big problem. Sometimes it can be subtle. The patient's in a lot of pain. Maybe there's some other injuries, and we'll talk about this a little bit more, but this is going to disrupt the physiology of breathing. Hemothorax, unfortunately in the field, there's not a whole lot to be done for this unless you guys are putting in chest tubes. And I won't go into chest tubes too much because this is mostly what we'll do in the trauma bay. I know Air Med will sometimes put in chest tubes if it's necessary, but so hemothorax is one of the 6 quick killers. And then pericardial tamponade is the last 6 quick killers. So when you see a patient with thoracic trauma, you need to go through these 6 things in addition to the ABCs. Airway is one. 4 of them are lungs. So tension pneumothorax, open pneumothorax, flail chest, and then hemothorax, and then the last one is heart. It's pericardial tamponade. So to go through them in a little bit more detail, airway obstruction is most often the patient's tongue. They've got a low GCS, their tongue goes back in their throat, and it's so easily fixed by either a jaw thrust or by one of these oral airways. This is a lecture on chest trauma, and I don't go into intubation and airway management really all that much, but this is something that you need to be doing first off before anything happens, because airway obstruction can kill a patient quickly, and it's, as you can see kind of by this picture, and oral airway, it's fairly easily treated. You also need to recognize subcutaneous emphysema. There could be a tracheobronchial disruption, and it's those Rice Krispies. I don't know if you guys have ever felt that. It's under the patient's chest and through their neck, and it's going to be just crackly. I've got some pictures to kind of demonstrate that. Tension pneumothorax, I do want to spend some time here. This is not going to happen when there's an open chest. That's an open pneumothorax. But if the air can't get out, but the air is going into the chest, it's going to be filling the pleural space, and oftentimes you have a one-way valve, so the air can go in, but it can't get back out. And you're going to start developing a lot of pressure on one side of the chest, and what that does is it compresses the mediastinum, and it compresses the heart. Specifically, the inferior and superior vena cava and the right atrium and ventricle. So you basically decrease your preload, you decrease the amount of blood that's coming into the heart, because there's so much tension pushing on it. And then you can't get blood going back out to the body because it's not coming in from the body. This is not an x-ray diagnosis. And what I meant earlier when I said this is an x-ray that should never have happened is this is something that when you start to see hypotension and here, these recognized clinically things. So hypotension is a bad sign. Absence of breath sounds on one side, and hyperresonance. If you're in the field, these are classic things that you should be looking for. You should be able to hear some breath sounds. I don't think that you're going to be doing percussion on the patient's chest. It would be great if you could, and were able to use that clinically. But tracheal deviation is a very late sign, and you really shouldn't see that because you've missed the diagnosis at that point. I think this difficulty bagging is a really important thing. And that brings up the next point, which is this is generally something that occurs after a patient has been intubated. So they are on mechanical ventilation and you're blowing air into the chest. It can happen in a patient who's breathing spontaneously, but generally doesn't. This is a patient who you controlled their airway and you have them intubated and you're bagging them and you just keep blowing air into the chest, and then all of a sudden they start to get difficult to bag, they're going to be tachycardic, and they're going to start dropping their blood pressure. And immediately when a patient's blood pressure starts dropping, especially after intubation like this, tension pneumothorax has to be the first thing that you think of. And there's instances where people have died because they've been reintubated, everything's been done, they're getting lots of fluids, and what's going on? If you don't think you hear breath sounds, sometimes even if you do think you hear breath sounds on this side, I don't think any trauma surgeon or any ER physician is going to fault you for putting in a needle into a patient's chest if they're hypotensive and have tension physiology. I think it's absolutely it's an okay thing to do. And it needs to be immediate needle decompression. This is done with a 14, maybe a 12 gauge angiocath. Prep the area. It's not a terribly difficult thing to do. This is the mid-clavicular line. So just take the clavicle right in the middle, go 2 rib spaces down, and just put the needle in. And if it is a tension pneumothorax, you should have a rush of air, and you should start to correct the patient's physiology. Unfortunately, I've needled a couple chests, and they have had a pneumothorax, and you don't always hear that great rush of air, but you leave the needle in there, and you shouldn't necessarily get blood. Sometimes you can get a little bit of frothy. It's if you hit the lung, it's not the end of the world. You can cause a pneumothorax, but you have essentially treated what could have been a tension pneumothorax. So, like I said, I don't think anybody's ever going to fault you for putting in a needle into a patient's chest if they have tension physiology. The pneumothorax, and this is the chest tube. You may end up transporting a patient. Y'all may put in chest tubes yourselves, and I don't go into how to do that all that much. Generally, this occurs in kind of the 4th to 5th intercostal space along the axillary line, and it's the definitive treatment for a pneumothorax and hemothorax. If there's a needle in a patient's chest, they're going to get a chest tube, and to correct that problem if they live. This is important. Never, ever, ever clamp a chest tube, because you'll arrive in the trauma bay and there will be a chest tube there, and the patient will be hypotensive from a tension pneumothorax that you caused by clamping the chest tube. And sometimes having that chest tube can make us think, well, they're hypotensive for other reasons. Generally, our surgeons will be going through and making sure that the chest tube is working properly, is in the right place. Sometimes we'll put in other chest tubes because we can't guarantee that it's necessarily in the patient's chest versus kind of in the muscle or in the subcutaneous tissue. But don't ever clamp the chest tube. If you're transporting a patient, they have pleurovacs that you can use. They also have Heimlich valves, and I'll show you a Heimlich valve in one of the next slides. In this one. So the sucking chest wound is the open pneumothorax. It's penetrated, it's through the parietal pleura, which kind of lines the inside of the lung. And if the hole is bigger than the trachea, which doesn't need to be that big, it's actually 2/3 the size of the trachea, the air is going to go in through the hole versus through the patient's lungs. And it can cause, it's going to be an open pneumothorax. Shouldn't be tension unless you close it off. But you're going to severely disrupt the patient's breathing physiology and their respiratory physiology. So the air fills the pleural space. This is an example of a 3-sided occlusive dressing, which is something that you can use in the field. They also have these special Heimlich valves. And what this does is it allows air out because they have a pneumothorax. Air's already gotten in. You want air to go out and not in. And these occlusive dressings will open up to let air out, and then as soon as you start sucking in, it's just going to close down and occlude off that wound. Now, obviously, I'm sure this patient feels fine with his open chest wound. Generally, your patients aren't going to be standing up, with no other signs of trauma. I'm guessing that this is probably a medical student who put this on to pose for a picture. But and a three-sided occlusive dressing does not need to be, it just needs to cover the wound and just have a way for air to get out. I'm also guessing that most paramedics will have access to these Heimlich valves. This actually looks fairly small. I can't imagine the open chest wound that would cover, but you can put that over it and then put dressing around it, and you're still going to have your Heimlich valve, so air can go out, but it can't get back in. You want to do high flow oxygen and possibly intubate the patient. If they have an open chest wound, they're going to be, it's a pretty severe chest trauma. And then you want to monitor for development of tension pneumothorax, especially after you've put this dressing on. Flail chest is, like I said earlier, it can be somewhat subtle, but it can severely disrupt a patient's respiratory physiology, and it can kill them fairly quick. It occurs when you have a fracture in two adjacent ribs and two fractures in each rib. So basically, you take a section of the rib cage, and part of it is broken away. If there wasn't muscle and parietal pleura, if there wasn't soft tissue all around it, you could just take a section of that rib cage out, essentially. And so what this does is you see paradoxical movement of the chest. Let me see if I have, there you go. So when patients inspire, when a normal person inspires, their rib cage goes out, creating a negative pressure inside the chest, which is what draws air into the lungs. If you loosen a part of that, that negative pressure will actually pull that portion of the chest in. So as they take a breath, portion of their chest will cave in, so to speak. And as you can see, this lung right here is filling up with air. This lung is actually collapsed. So it doesn't necessarily mean you have a pneumothorax. Often you will, but this lung is not working properly. When they exhale, this lung is smaller. The rib cage is going to come in a little bit. The diaphragm is going to come up. Here, it's positive pressure to exhale, to push the air out, and this is going to push the rib cage out. So you're going to get this little section of rib cage that comes out. So this is what the paradoxical movement of the chest is, and it's is going to occur with inspiration and expiration, but inspiration is where you usually note it. Often they'll have asymmetry, so if you look at the patient from the foot of the bed, it's fairly interesting to see. It occurs in blunt trauma. It's often with older patients. They maybe have a little bit of osteopenia, a little osteoporosis, and generally they're going to be in a lot of pain. If they have a flail chest, there's likely, like I said, there's likely a pneumothorax underlying it. There may be a hemothorax underlying it. These patients are going to be very, very sick. The treatment for these patients is intubation and positive pressure and lots of pain control. And sometimes some surgeons are now plating ribs, which is obviously not in the pre-hospital setting, but just to let you know that this is a very, very severe injury, often with a lot of underlying pathology to the lungs and possibly the heart. So that's your flail chest. The treatment in the pre-hospital setting is going to be stabilize the segment with a bulky dressing. Some textbooks and some articles talk about using a pillow on that side. I don't think I would recommend wrapping the chest with anything, partly because you have spine precautions in all of these patients, so that's going to be difficult to do anyway, but also because when they get to the trauma bay, that's more stuff that we have to cut off, and they're going to be very sick patients. We want things to happen fairly quickly. Don't put sandbags on it. Put pillows on it. The sandbags can actually push it in, and you're going to be doing exactly what we don't want to happen with the flail segment. So that we want something kind of slightly compressing it so when they expire it doesn't go out. We know that when it inspires it's going to go in. It's a flail segment. And then pain management for the patient as well as they can tolerate it. Again, these are going to be fairly sick patients. You're going to watch for respiratory failure, have a low threshold to intubate these patients if they're getting very sick. Again, intubating these patients is best done in the trauma bay in the best circumstances, but if they need it, this positive pressure, ventilation, and intubation will certainly be they're going to get it anyway. So, also, if they're tolerating it, I say this kind of as a caveat, easy on the volume because there's going to be associated pulmonary contusions, and if you flood the lung, you're going to have a really hard time oxygenating the patient. That being said, I think I would rather see patients over-resuscitated than under-resuscitated when they come in. So it's okay to have a little bit of permissive hypotension. And what I mean by that is blood pressures in the 90s to 100s. We don't need their blood pressures to be in the 130s systolic. I definitely think getting 2 large IVs and giving them volume is important. If they're sick and there's underlying pathology, in addition to the flail chest, maybe a hemothorax, they need a lot of volume and forget about this. Just if they have a flail chest only and they're doing fairly well, we don't need to flood them with a lot of normal saline. We can do that when they get to the trauma bay and we'll flood them there. But we can talk more about that when I get to pulmonary contusions. Hemothorax is the fourth kind of lung pathology, so to speak. This will also often be accompanied by a pneumothorax. This is going to be blood that fills up the pleural space. Let me see if I have there's a chest x-ray right there. And this isn't actually even a massive hemothorax. But the problem here is that they're losing blood, and they're losing it into their chest. It occurs mostly in penetrating traumas, and obviously can occur in major blunt trauma. There's a lot of bleeding that it can be coming from. If they're bleeding from a lung or an intercostal vessel, it may not be that dramatic. If they're bleeding from one of the great vessels, like the aorta, for instance, or the heart, it will be very dramatic, and this patient will probably lose vital signs at some point. Massive hemothorax is generally going to be from the great vessels in the heart. And this needs to be recognized clinically and just treated as shock, treated as hypovolemic shock. Large bore IVs, lots and lots of fluid. What you're going to see is decreased breath sounds, dullness to percussion, and difficulty ventilating. I think the physiology, the shock physiology, they're going to get hypotensive. You're going to have difficulty ventilating them. Does that look like a pneumo or a tension pneumothorax? Sure. Should you put in a needle? Yes. Again, nobody's going to fault you for saying, well, I couldn't tell if it was a tension pneumothorax versus a hemothorax. And like I said, often these will be accompanied by a pneumothorax. It may not be tension. The hemothorax can be so severe that the blood is causing all the tension, but putting in a needle into the second intercostal space, mid-clavicular line, it would be fine in this situation. If you have the capability to put in a chest tube, again, that's for a little bit more advanced kind of air med and helicopters type stuff. And I think there's actually a course on that sometime soon. But the definitive treatment for this hemothorax is going to be either a chest tube and possibly a thoracotomy, either in the operating room or the emergency department. If they do have a massive hemothorax, the treatment is go fast. Get them to the trauma bay as fast as possible. You're going to treat this as volume loss. You're treating as hypovolemic shock, and they need a lot of fluid and give them a lot of oxygen because the little blood that they have needs to be very well oxygenated if we don't want the rest of their tissues to be lacking oxygen, especially their brain. There could be tension from the blood, like I mentioned. There's going to be shock from the volume loss. And then the definitive treatment will involve the chest tube and possible thoracotomy. One of the things, this is generally why we would do an emergency department thoracotomy, and is because of massive hemothorax. Our main, I guess what's important for us to know is when they lose their vital signs. So a patient who loses their vital signs in the trauma bay from a blunt trauma will do a thoracotomy in that situation. If they lose their vital signs 10 minutes before they arrive and it's been from a blunt trauma, from a motor vehicle accident, generally we won't do a thoracotomy because those patients don't do very well. The penetrating trauma is a little bit of a different story. If they lose the vital signs 10 minutes before they arrive, we can still do it. Patients still don't do great, but we're going to want to know at what time did the patient lose their blood pressure? What time did they lose their pulse? You're obviously not going to be doing a thoracotomy in the field. It's just going to be drive faster and more volume. Just keep dumping the volume in. So hemothorax, you can either treat with the chest tube, which is generally what we'll treat with. We have certain criteria that we use to determine when they get this, which is what a thoracotomy looks like. You just open them wide open and you try to find the source of the bleeding, etc. And then the last one of these quick killers to think about is a pericardial tamponade. Generally, this is from penetrating trauma. It's almost certainly never from blunt trauma. I actually have heard a trauma surgeon say that he's never seen it from blunt trauma, but I'm sure it can happen. There's rapid accumulation of blood in the pericardial space. The problem is the pericardium, which is the sac that surrounds the heart, is fibrous. It's very non-compliant. It's not elastic. So it doesn't stretch well. So when blood gets into it, it compresses the heart. And specifically, it compresses the right ventricle and right atrium, which, just like with tension physiology, you just don't get blood going into the heart through the lungs and back to the body. So they're going to drop their blood pressure because there's no blood going through the heart. In trauma, it's going to be rapid accumulation. We can see this in medical conditions that occur over a long period of time, and often then they'll be a little bit bigger because the pericardium does stretch a little bit slowly. You'll see compression of the heart, it's the right ventricle, and there's going to be decreased blood flow. Cardiac output falls, and this is interesting. So you see dynamic blood pressure changes with volume. And this is it's part of the, cardiac physiology where you've got compression of this right ventricle. If you keep dumping in volume, you're going to increase the preload to the heart, which is increase the pressure of blood going into the heart. And you can actually start to see their blood pressure rise back up. And it may actually look like, well, boy, I wonder where this patient's bleeding from because we keep giving them volume and their blood pressure comes back up. And then as soon as the volume gets turned off or you're not giving them enough, the blood pressure will fall again. So that's what I mean by dynamic blood pressure changes with volume. Beck's triad is something we talk about in medical school a lot. It's actually not very sensitive. I think you see it in 40% of the patients. You'll see distended neck veins. You see hypotension and decreased heart sounds. In the pre-hospital setting, I don't know how important this is going to be. If you just see distended neck veins, maybe it would be helpful to point out to us when the patient's hypotensive. I would be more interested to know when you came in the report, well, the patient got hypotensive twice, and we gave the patient fluids, and it came right back up. Their blood pressure did fine. So also, you see decreasing pulse pressure, which is related to the blood not going through. And then you see pulsus paradoxus, which is something, again, you learn in medical school. Basically, it's blood pressure variation with respiration. These things are things that come up a lot for us, but I don't know how important it is in the pre-hospital setting. I think it's going to be hypotension is the main thing. Right. It's the rate of accumulation. So you can have 10 to 20 cc's of blood that is going to collapse the right ventricle, and you get tamponade. So tamponade is not. Tamponade is a physiologic term. It's not referring to blood around the heart. Pericardial effusion refers to blood around the heart. Tamponade means low blood pressure, rapid heart rate, and the patient is in shock because of the blood around the heart. So these are two things. You can have 100 cc's of blood around the heart as a pericardial effusion and not see tamponade. And that happens in some patients with cancer. You see it in uremia. and it's a slow accumulation and allows the pericardium to expand a little bit. And so you get a pericardial effusion, but you don't see tamponade, you don't see shock, and the collapse of the right ventricle. So tamponade also refers to when we use the ultrasound, we can see the right ventricle collapse with the blood. So that's very important. It can happen quickly. Treatment is a pericardiocentesis or pericardial window. These aren't for the field, and I would say just move quickly, and they're probably going to be volume responsive if you see this. Again, this is going to be a patient who you're not necessarily going to know what's going on. They've got chest trauma, and they're hypotensive. Give them fluid. Give them lots and lots of fluid, because they may respond. If you notice that the neck veins are distended, then you can postulate that it's tamponade. But again, this is a diagnosis that's going to be made by ultrasound and by fixing the problem, essentially. So those are the 6 quick killers. Just to review them real quick, it's airway obstruction, it's tension pneumothorax, massive hemothorax, open pneumothorax, flail chest, and tamponade. So 4 things with the lung, 1 with the airway, 1 with the heart. These things are far more common, and these are things that you're going to be seeing that the patient will not be in extremis. They're not going to be too bad, but they still definitely need to be evaluated. This seatbelt sign, I wanted to point this out. You can see this right here, and this is really important to us. If they've got a seatbelt sign here or on their abdomen, and what it is it indicates that, good, the patient was restrained. They don't have a whole lot of obvious chest trauma, but there was a large deceleration injury. And the mediastinum, which contains the heart, the aorta, the pulmonary vasculature, when it has that deceleration injury, or when the whole chest wall decelerates, that mediastinum can continue moving forward for a moment. And you can get things like aortic rupture and aortic transection. You can get tracheobronchial injury, myocardial contusion, pulmonary contusion, less so. But this seatbelt sign can be very, very important when they come in. So we pay a lot of attention to this. If they have a seatbelt sign, they get a chest CT, even if they're not that sick. It's to look for things like this. So rib fractures are probably the most common thing. They're going to be 50% of thoracic trauma will have some kind of rib fracture. It's not necessarily going to cause a pneumothorax, although that should be the biggest consideration. I think on this picture you can see these 3 ribs are fractured right here, and then this is a little bit of lung, but you don't have lung on this side. So rib fracture, underlying problems, think about pneumothorax and think about tension pneumothorax. Always should be going through your head. If they don't have a pneumothorax, it's just going to be very painful. Like I said, it's the most common traumatic chest injury, up to 50%. It's usually going to be these middle ribs, the 5th to 9th rib. These are pretty well protected, and then these are very well protected by the clavicle and the scapula. If it's lower down here, suspect that there's probably going to be a liver or spleen injury. And I would give these patients a lot of volume. I think it would be fine if they've got low rib fractures. And they're going to be tender to palpation. They're not going to want to take a deep breath. And that actually ends up being part of the problem in the hospital, or being the major problem in the hospital, is they won't take a deep breath, and you get fluid that accumulates at the bases of the lungs, and they can get a pneumonia from that. So little old ladies who fall and break their ribs can be very, very sick. Oh, up here? Yeah, so if this is more significant because you're going to be getting into head and neck injuries. So all of these patients should be in very strict spine precautions, but you just worry about neck injury. You also worry about pneumothorax. You can worry about the tracheobronchial injury. There's some important vessels, the carotids, that are going to be right through here, as well as the subclavians. So you can see some pretty severe vascular injury in these high rib fractures. They're really uncommon to see, though. We only see them in about 1 to 2% of rib fractures are going to be these high rib fractures. Again, because you have the clavicle and you have the scapula that is very protective of that area. Also, they're very small ribs. So rib fractures are easier to break if it's a big, long rib that comes around. Both because of the space of the rib, but also because it's just, they usually break in two places. So this, you want to splint with bulky dressing and pillows. Again, I'm not sure I like this a whole lot. If we know for sure that it's a isolated rib injury, then maybe you could splint like this. I saw this in kind of an EMS textbook online. I think this is okay. If the patient had severe thoracic trauma, I'd rather not see them wrapped like this when they come into the trauma bay. If this is a little old lady who fell, it was ground level fall, and she's just complaining about a little bit of pain with breathing, then sure, you can splint them so that they're splinting the ribs when they transport. It's going to be more comfortable for them. But if there's any thought that there's something else going on, if there's any abnormal vital sign, then put a pillow on it and pain control as you're able to. But again, you don't need to wrap it unless you really think it's the only thing going on. High flow oxygen is definitely good. It's going to help open up some of those airways that aren't open down below. You want to encourage deep breathing. We're going to do this in the hospital a lot. We admit patients for this kind of stuff. And then, again, always watch for hemo and pneumothorax. So, again, tension pneumothorax should be the first thing on your mind. So, pulmonary contusion. You see it a lot with rib fractures. It's very significant cause of morbidity and mortality. It's just bruised lung, essentially. I wish I had a CT scan that I could show you, but it's usually around the outside of the lung, and it's bruised. There's bleeding into the lung, just like if you bruise a muscle. The patients will, in the field, probably be doing fairly well. This is something we see in the hospital the day after they've gotten a lot of fluids. And again, this is where giving them a ton of fluids, you can get into a problem with volume overload because you just flood the lungs. And sometimes these patients need to be intubated. This patient's intubated right here. You can see the ET tube on the chest x-ray. You can get into trouble. This is not something in the field that you want to worry about a whole lot. It's usually going to be blunt trauma. A lot of these patients get pneumonia, and a lot of them will be put on antibiotics, and a lot of them will need to be intubated because of problems ventilating and oxygenating. So, again, in the field, this is just something to consider. In a severe blunt trauma, this is something that we're going to be looking at down the line. So, myocardial contusion. This is going to be something that you're going to see in the field, and it can be fairly scary. I wish I could tell you that there was an easy treatment for it, but there's not. Oftentimes, this is going to be a blunt trauma. It's going to be a steering wheel, and it, just like you've bruised the lung, you can get bruising of the myocardium, so it's like a Charlie horse of the heart, basically. If you get a Charlie horse of your thigh, it hurts and you don't want to use it. And when you get a Charlie horse of the myocardium or myocardial contusion, it's going to hurt. They're going to complain of a lot of chest pain. Get an EKG. If you have capability to do a 12-lead, do a 12-lead. These patients need to be very closely monitored. You can see ST elevation. So it doesn't necessarily mean that there's a coronary artery that they're going to go in and cath and stent, but it does mean that there's heart muscle that's dying, and we will see elevated troponins, we'll see elevated CK and CKMB, which are basically just enzymes in the heart that we look for heart attack. There's going to be a major risk for dysrhythmia, and if these patients go into VTAC and VFib, then we go into ACLS, and you do shock them. And this, generally they don't. You'll see some ectopy, which means you're going to see frequent PVCs. You're going to see possibly some PACs. You may see some widening of the QRS. Essentially, though, it's just going to be close monitoring, and I would probably put some pads in the patient. I don't think, especially if they've got a lot of ectopy, nobody's going to fault you for coming in and say, hey, the patient's been complaining about bad chest pain. They have ST elevation right here. We were just getting ready. I think that's a reasonable thing to do. Again, it's not from a coronary artery that's been occluded. This is just badly bruised heart muscle. And these patients get monitored very closely in the hospital because they can develop pretty significant dysrhythmia. Treat the dysrhythmia just like you would in the ACLS algorithm. Diaphragm rupture is blunt trauma to the abdomen, and sometimes you get the chest, but basically you rupture your diaphragm. It opens, the intestine go up into the chest. You're going to see patients having difficulty breathing. Sometimes they can get shoulder pain, which is because the nerves that go down and into the diaphragm also innervate the shoulders. It's called referred pain. They can get cyanosis. They can be, they're probably going to be tachypnic, and they will likely also have hypoxia. I put this NG tube in to decompress. I would do this if there's going to be a long transport. If you're taking them from an outside hospital, then this needs to be done in the hospital, not in the back of an ambulance. But we will often put an NG tube down to decompress. Because basically the problem is you've got all these gastric contents and abdominal contents, and it's filling up the chest cavity, and the lung can't expand. It's got no room to expand. It almost always happens on the left side. I've heard some trauma surgeons say it never happens on the right, but I think I've seen a picture of it. And that's, of course, because the liver is a big, solid organ, and it's protecting against diaphragm rupture, essentially. Esophageal rupture, this is something the patients get very, very sick from, but it's going to be a day out. You can see air in the mediastinum when we do a chest x-ray. In the field, I don't know what to tell you to look for. Specifically, they're going to have a lot of chest pain. They may complain about difficulty swallowing. I don't think this is a very, very important thing for the pre-hospital setting. This is more something that in severe chest trauma we see as being a significant cause of morbidity because they get badly infected. These patients can die pretty quickly because their mediastinum gets badly infected, and it's difficult to treat. So, again, it's not something we're going to see a ton of in the pre-hospital setting as being important, but it's usually from penetrating trauma. So we just had a discussion about this in our conference for emergency medicine this morning, and it's traumatic aortic rupture. Almost all these patients die, and it's because they just basically, their blood, it's like you just occluded the heart, essentially. The 10% of people that do not die, only 20% of these will survive the first hour. So this is a bad, bad injury. In the pre-hospital setting, get them there fast. You won't know that this is going on specifically. They're going to have terrible blood pressure. The blood pressure may be a little bit different in both arms, which would kind of clue you into the diagnosis, but I would give them fluids and control their pain because they may be dissecting as well, and we want to keep their blood pressure a little bit down. These are patients you don't want their blood pressure to be up in the 160s systolic. It won't be, but this is the whole rapid deceleration thing that I was talking about, and it can also happen from penetrating trauma. Essentially, if the patient is alive, the only thing that's holding their blood into the aortic root, aortic arch, is the adventitia, the outer layer of the blood vessel that's going around the aorta and the heart. And these are going to be terribly sick patients. So, aortic injury, so you fluid resuscitation, rapid transport. This is generally surgical, and you do just high oxygen airway management. So typical stuff. This it's a cool looking picture because this it looks like aortic arch. I think the car, the aortic arch, it's a little bit similar. Kind of interesting. Tracheobronchial injury. This guy right here, you can see all this edema up here, edema through here. He's also just a fat guy, but here you can see they're pushing, and what they're feeling is the Rice Krispies. They're feeling crepitance. So it's this little crackly popping thing, and it's difficult. I think that's a fairly good description. When you feel it, it feels like there's bubble wrap underneath the skin. Very easy to pop bubble wrap, but it's going to feel like there's Rice Krispies or bubble wrap. It's this kind of crackly sensation. And this should alert you to a couple of things. One, if you feel that, you very well may have a pneumothorax. And that's usually what this is from. We had a patient, I guess I don't think it's violating HIPAA, but this is the guy that crashed his car. I showed you a picture of his thing, of the accident earlier. But we felt crepitance on that side, and even though he was an extremis, he was dead essentially on arrival, but we put a chest tube in on that side because he had crepitance, and we said he's got a pneumothorax, or he's got disruption of the tracheobronchial tree, and we can't necessarily fix that. So if the trachea or one of the bronchi becomes transected, you can get air that tracks up and through the chest and into the neck and into the face. And they're going to have crepitance, and they can have this kind of crackly sensation all up through their face. They're going to be really sick. They could be coughing up blood. They're going to be cyanotic. You can see this with the upper rib fractures, like I was talking about earlier. They're going to have noisy breathing. In this situation, I would control the airway, maybe intubate, and I would probably intubate deep. You're not going to have a chest X-ray to tell. You won't have a bronchoscope, but I would err on the side of going deep. And especially if it's a tracheal transection, they're going to be very, very sick. If they're not in extremis, if they don't need intubating, just because you feel air doesn't mean they need to be intubated. Because it could be from a pneumothorax, it could be a small tear in the trachea, and then I would say don't intubate them. So if they're very, very sick, go ahead and intubate deep, but otherwise don't. So in summary, chest trauma is going to be in a multiply injured patient, and this is one thing I do want to bring up is if they have severe chest trauma, we should assume that they also have a severe thoracic spine injury. C-spine, they absolutely need a collar. They possibly have some head injury, but we should assume that they have a thoracic spine injury, and that's pretty high real estate. So these are patients that it's difficult because they could be very, very sick and low blood pressure and tachycardic and all that stuff. But spine precautions are really important in these patients as well because a lot of them have concomitant thoracic spine injury. And there's a pretty high mortality, up to 25%. The quick killers, recognize these. Don't miss a tension pneumothorax. That would be, I think of all of this stuff that I've said today, the tension pneumothorax is the worst thing to miss because it's easily treated with a needle and it can kill a patient, and there's pretty much no defense against missing a tension pneumothorax. You want to reassess the patient constantly. Some of these quick killers will develop. Flail chest will develop a little bit over time. A tension pneumothorax can develop over time as well. And like I said, after they get intubated or they're being transported, maybe they're being transported in the air. I don't know how many of you guys do air transport or anything, but certainly if they're changing elevations, they can develop a tension pneumothorax from an otherwise non-tension pneumothorax. And then rapid transport is very important in these patients. All of them should be on high flow oxygen, and don't neglect other injuries like spine injuries. And that's it. Yeah?